And there have been several great reviews in the last couple of years, including this one that includes the Asian Pacific Society of Cardiology and representation from India. So we know that diabetes is an epidemic causing cardiovascular death and disability. This is a huge issue in the United States and a huge issue in India and generally around the world. A third of patients with cardiovascular disease have diabetes, driving risk of recurrent events. And so cardiologists have to treat diabetes in their patients to reduce this cardiovascular risk, and now we're not doing a good job on that. So it's a critical need for cardiologists to take a leadership role. And I know this is true, again, in the United States, that our patients managed by cardiologists are simply not having these treatments implemented as effectively as they need to be. So I think in the broadest terms that the data for GLP-1 receptor agonists versus SGLT2 inhibitors could be summarized that GLP-1 receptor agonists have the benefit of weight loss, especially at higher doses, and of reducing vascular events perhaps more substantially than SGLT2 inhibitors, which have the distinct advantage of renal protection and reducing heart failure events. But both of these classes of drugs are good. Again, Dr. Nambi talked about the obesity being such a big part of the problem, again, around the world. And so I think the promise of GLP-1 receptor agonists, both treating obesity as well as vascular risk, is clearly a very appealing attribute of those drugs. And then the guidelines are recommending at 1A level of recommendations that for patients with diabetes and moderate or high-risk cardiovascular disease, that SGLT2 inhibitors and selected GLP-1 receptor agonists, right? That's an issue with the GLP-1 receptor agonists. It's liraglutide, semaglutide, dulaglutide that have the data, and there seems to be some heterogeneity in the effect of these drugs on cardiovascular risk, and then SGLT2 inhibitors for reducing heart failure. And then the American Diabetes Association went a little bit out on a limb this year and actually recommended that it be considered that both GLP-1 receptor agonists and SGLT2 inhibitors be used in patients with diabetes and high cardiovascular risk to reduce that risk. And I think that's becoming accepted as now a reasonable possibility. For CKD, the recently presented and published EMPA-Kidney trial provided the compelling data that we really needed, that for the broad population of patients with CKD, generally with a GFR less than 45 or even higher with albuminuria, that there was this important reduction in this composite outcome of progression of renal disease and cardiovascular death. This 28% relative risk reduction, also all-cause hospitalization reduced. For heart failure, I mean, this is so exciting that we now have these 4 trials, 2 in HFrEF, 2 in HFpEF. They all show exactly the same thing, regardless of ejection fraction, regardless of the presence of diabetes. SGLT2 inhibitors are so effective at this 20 to 25% reduction in cardiovascular death and heart failure hospitalization. And the benefit, as we also talked about earlier this morning, begins almost immediately. And you don't have to worry about titrating the dose. There's only one dose. It's so easy to remember. It's 10 milligrams of DAPA or EMPA. So it's these drugs and they have very few side effects. You just heard about this meta-analysis. This is the most recent one, 90,000 patients. That one of the nice things here is this estimate of the effect on cardiovascular death of 14% now is becoming more and more narrow. So we can be really confident that, again, across the spectrum, with or without diabetes in these populations that have been studied, there's this important benefit. We've also heard a little bit about the risk. There is an increased risk of ketoacidosis, so it is important that when patients get sick and they're on these drugs, we hold the drugs. But UTI is actually, this is really a misperception. There's not an increased risk of UTI. If you look at depending on which meta-analysis you look at, it's either no effect or even numerically fewer UTIs with SGLT2 inhibitors than with placebo. It's growing yeast infections that are increased, but not UTIs. So how are we doing then with use of these drugs? Well, again, this is data from 2018, a commercially insured population in the United States, but only 3% of patients who had diabetes and atherosclerotic cardiovascular disease were on a high-intensity statin, an ACE or an ARB, or an SGLT2 or a GLP-1 receptor agonist. We're really failing, at least in the United States right now, at using these treatments. Only 25% are on a high-intensity statin. I mean, that's appalling in and of itself. So big opportunities to improve care. And I think part of the issue with the diabetes intersection is there still is this tendency for some cardiologists to defer to the primary care or diabetes care specialist who's traditionally focused on the blood sugar, is expert in hypoglycemic medications and complications of diabetes, but refers to the cardiologist largely for cardiovascular protection, whereas the cardiologist focuses on the more traditional risk factors, the management of the disease, but is deferred to the primary care or diabetes care specialist for the diabetes medications, and the patients are falling through the cracks. So my take-home points then are SGLT2 inhibitors and GLP-1 receptor agonists are cardiovascular drugs primarily. That's their benefit. It's not controlling blood sugar. It's reducing cardiovascular risk. Few of our patients with cardiovascular disease and diabetes are on these treatments, as well as other proven protective treatments to prevent cardiovascular events and mortality. And most of our patients with cardiovascular disease and diabetes, even without heart failure, will benefit from starting an SGLT2 inhibitor or a GLP-1 receptor agonist. Thanks for your attention.